Good afternoon, everybody, and good morning those watching from other parts of the world, and good afternoon or evening to those watching from other parts of the world. Welcome to the Coffee and Ann room in Geneva, where we have a gathering from WHO, from UNAIDS, from the Global Fund, maybe some others that we're not sure about, from UNITAID. Thank you. And welcome to the 30 or 40 people that we've seen online from our country offices around the world. So that's a good turnout. As you know, after each of the big international AIDS conferences, we try to have a very brief, well, not a very brief, but a quick overview of some of the things that several of us saw that we thought were interesting or exciting. My name, for those of you who don't know me, I'm Peter Godfrey Fawcett. I'm the science advisor here in UNAIDS. The AIDS conference is one of the conferences that is extremely well represented online, so we will be going through a lot of material very fast, but anyone who wants to chase up on things that they're particularly interested in, do be aware that if you go to the conference site and you look for program online, you can see a huge amount of detail in terms of slides, in terms of electronic posters, in terms of the videos of the presentations, so do go back there if you want to check out more things. We'd advertised that I was going to talk about epidemiology, cures and PrEP. In fact, we've decided that there's so much this time that we're going to postpone some of the epidemiology discussion till next month, when we're going to have a visitor from the pop art trial who'll come and talk to us about some of that and some of the implications of the big studies that were presented in Amsterdam. So I'm going to move straight on to talk about PrEP, transmission, cures and vaccines. And I'll go quite quickly so that we can get through it, because I've got a lot to get through. So the first big study that was presented was the Partner 2 study. This was a study looking at transmission of HIV in serodifferent couples where the HIV positive partner has a suppressed viral load. And it was a follow-on from the first phase, done in multiple European sites. And during this period of the follow-up, they found 15 seroconversions amongst HIV negative men who had sex with men. But in all of those cases, they were not related to the partner in the study, suggesting that the infections had come from outside. In 11 of those, the participant reported that they'd had outside sex, and in the other 4, the phylogenetics suggested that they'd had outside sex. And what that means is that there have been absolutely no transmissions in this context, and so we have no linked transmissions, and you'll see that this comes with an upper 95% confidence interval. Obviously, the longer you follow up and the more acts that you follow, the more confidently you can say that it really is zero, and those are shown in the second and third columns. They've now followed up 76,000 sex acts and seen no transmissions, and that means that the confidence limit is now down at 0.23 per 100 person years, and as Alison Rogers said in presenting it, that means on average 400 years on average for somebody to acquire HIV in that situation. So we can really say that transmission does not occur when people are virally suppressed, whether they're in heterosexual, in MSM contexts, and even when STIs are present. Moving on to PrEP, WHO gave most of the sort of overview of PrEP, and I would just like to draw your attention not only to the amount of work they've done, but in particular to the app on the right-hand side of the screen that is a downloadable app onto your phone that allows you to look at all the implementation modules that they've done for healthcare workers around the place. Very useful, very easily navigatable. I recommend it. The app focuses on the direction that many countries are beginning to think about. First of all, thinking about the epidemiology, then focusing down on population groups within that epidemiology, and then thinking on individual risk, still bearing in mind that the recommendations are that we're providing PrEP for people at substantial HIV risk, which is still seen as being around 3% per year as a way if we need to focus on that and measure it. So the good and exciting new news that came out in Amsterdam was the Prevenir study, which was on-demand PrEP. So many of you will be aware of the EPOGAY study done also by Jean-Michel Molinar, showing that taking PrEP tablets, Truvada tablets, just before sex, in the 24 hours before you have sex, and then another tablet after sex, and another tablet after that, a total of 4 tablets in total, was effective in the EPOGAY study. And so this is now an open label study where men are given the choice, and this is entirely amongst men having sex with men, given the choice between taking a daily tablet of Truvada or using Truvada, that's TDF-FTC, on demand before and then after sex. And what they found is that so far they've followed people up for roughly 500 person years in each of people who've chosen one or the other, and so far they've seen no seroconversions. Now, of course, the challenge is that you don't know quite how many seroconversions they would have seen in the absence of PrEP, but it seems reasonable to think that there would have been a background incidence of some 3% per year, because that would be typical in the sort of men who were coming into these studies, and they know roughly what they were doing and how many times they were having sex and so on. So they imagine that they prevented 85 HIV infections. But I think that the interesting point is that for men who have sex with men, PrEP on demand seems to work basically as well as PrEP daily. It's not a direct, formal, randomized comparison, but it's very encouraging that this is an alternative that allows for PrEP to be taken on demand, making it cheaper, making it more convenient, and perhaps particularly suitable for people who aren't having sex every night, as some of us aren't. Perhaps in contrast, when we move to the African context, and there's been a lot of talk about PrEP for adolescent girls and young women and other key populations in Africa, the countries that are leading the way in implementation are really Kenya and South Africa. And it's been a lot of work. There have been clinical trials, there have been demonstration projects, and then they've gone through a whole long process to finally reach a national PrEP framework in South Africa. And there was a whole session devoted to the rollout of that program. They focused naturally enough on the parts of Kenya that have much the highest burden, remembering the process of epidemiology, then populations, then sexual risk. They collect data on sexual risk as they go along. And you can see that they've gradually scaled up. So they've now started more than 14,000 people on PrEP in Kenya. Notice that half of these in the pie chart are in discordant couples. And that's because a lot of the research work in Kenya has been focusing on serodiscordant couples. So a lot of the focus of the Kenyan rollout has been to continue that partner's approach and to give PrEP to the negative partner in a discordant relationship until such time as the positive person is virally suppressed and is no longer able to transmit. So it's a little bit different from the way some of us think of PrEP when we just think of it generally. However, they are also giving it, as you can see, to plenty of people in other risk categories and through many delivery systems, the most common being through their CCCs, which are their HIV treatment centres, that most of those facilities are now able to provide PrEP as part of the national PrEP plan. An interesting presentation focused on giving PrEP to pregnant women, and this is interesting partly because it's within the routine delivery system, and partly because pregnant women may indeed be a population at considerable risk of HIV just because they're sexually active and because they're of the age group that HIV is most common in. So these are just some references, if you want to look back at them, that John Kinuthia presented on the rates in pregnant women, showing that it was actually higher than in their serodiscordant couples. And so they've started a project called PRIA, again in a high burden situation, so it's different from many other situations in Kisumu County, where they've asked 9,000 negative women whether they want to take PrEP and talk to them about it, and about a fifth, 22%, have said, yes, I would like to take PrEP. I find it slightly distressing that when you look at the reasons that people want to take PrEP, they give you a slight insight into some of the sort of sex that's going on in Kisumu. The reasons that people want to take PrEP is that they're being forced to have sex, that they've experienced intimate partner violence. So, you know, it's not a sort of cozy, I'm just protecting myself in a loving relationship necessarily. It's quite a sort of a difficult environment in which PrEP is being delivered. And the reasons for not taking PrEP reinforce that, I think, that women in Kisumu in this project are often not completely under their own control. Autonomy is not there, so people have to consult with their partners. Pleasingly, people don't want to start PrEP because they feel they're not at risk. The question, of course, is whether that perceived risk and the real risk overlap properly. Pleasingly, they're not so worried about the effect on the unborn baby because we know that PrEP is safe. And sometimes, but only in a small number, is it because they know that their partner is virally suppressed. Looking at other PrEP in Kenya, there have been demonstration projects going on since 2013, and now looking at the numbers when people have actually started, about the same number of women who said they would want to take PrEP amongst adolescent girls and young women actually took it up when it was offered to them. But what's very sobering is that people start on PrEP, but they simply don't carry on with PrEP. And people talk about this as being, well, there are seasons of risk and people may or may not want. But the reality in this program in Kenya, which is one of the most advanced in Africa to date, is that by the time you get to 10 months, very few of the people who initially said they wanted to be on PrEP are still taking it. And when you ask why, you can find why people want, and some of those are as we'd expect, and I'm afraid I'm not going to have time to read the quote, so you'll have to go back to these on the slides. But there are the reasons of providing greater self-confidence, of knowing that it would be protective, of discussing it with their partners. But there are also considerable barriers, again, often relating to who's going to know they're taking PrEP, whether people are happy to do it, whether their husbands will allow them to do it, and even that if you're not in a good relationship with someone, the noise of PrEP pills rattling in your pocket or in the container can make people think that you're on antiretrovirals because you're HIV positive, and so there can be conflation and coming together of some of the stigma. I think we've heard a lot of these stories before. Similarly, Jordan Kiongo has reviewed the PrEP data for different populations in Kenya and seeing that it's not just the young women where the retention falls off quickly, but also for female sex workers and even for men who have sex with men. There are smaller projects in Kenya, particularly around Kilifi, for men who have sex with men, and the numbers of people staying on PrEP is remarkably low. So this is obviously an area that we're going to need to work much harder on if PrEP is to have any real impact in these sort of scenarios. The reasons that people drop out, some of them are side effects, and we know that side effects are there to begin with but often go away. Some of them are because people, when they really start thinking about it, don't really consider themselves to be at risk. And I mentioned before, we need more research on the extent to which self-perceived risk and, if you like, genuine risk overlap, and I don't think we really know that very well. And then there are certainly misconceptions and myths around, and we've heard people in Kenya thinking that PrEP might make you impotent, that it might be a way of family planning, that it might reduce sexual urges, even a way of, quotes, eliminating Kenyans. So, and these beliefs came out in discussions both with clients, but even with the healthcare workers who sometimes don't support the use of PrEP themselves. Slightly different reasons amongst the key populations as opposed to the adolescent girls and young women. Key populations are perhaps more engaged, and they're worried about the PrEP packaging, the colour of the pills, pill sizes, the recruitment process and getting into service, whereas the adolescent girls and young women are perhaps more worried about social harms and peer pressure. And the difficulty of engaging with their peers, their elders, their partners. The reasons that people want to take PrEP, again, differ slightly, but in general, it's that if you provide a friendly service that is open to the particular population you're working with, then people are much more likely to come and engage. And that, that's fairly common sense, but it remains extraordinary how often it comes up in presentations. I'd now like to move gear completely and move away from PrEP towards the issues of cure, because despite the progress we've made, many people still see cure as an extremely important topic. And in surveys, for instance, amongst gay men in Amsterdam, where people have very good access to treatment and are taking a pill a day, you still find that 3/4 of gay men say that they see a cure as very important as a research agenda. So I think this remains an important agenda. You can see that a lot of the investigators, a lot of the money is in the US, Australia, our friend Sharon Lewin in the middle there, who works closely with UNAIDS, Steve Deeks, you may be able to see up in the top left, my favourite investigator, and the only African I can see on this picture is Lish Ndlovu, down at the bottom right. He's my favourite because I taught him as a medical student in the University of Zambia, and he now lives in Hawaii, where he enjoys the sun and doing research on HIV cure. Some of you at the top left will remember the Mississippi baby, which was a great sort of excitement that maybe when you stop treatment, people could be cured, but unfortunately she rebounded. And there have now been multiple cases, unfortunately, where people think that the virus has gone away, and then in due course it comes back. And one more of those was presented in the meeting. Steve Deeks, who is one of the sort of doyens of cure research, really made us all reflect on in the pre-conference on HIV cure about the fact that we've still got a long way to go, and that unfortunately, if anything, there tended to be rather disappointing news at this conference, and that we do need work to try to see how to prolong HIV remission. HIV remission commonly occurs, but unfortunately doesn't last, and we need to find out how to affect the immune system to make it do so. So this was just one example of the so-called Essen patient, who is another example of someone like the one man who has been cured, who was cured with a stem cell transplant because of his leukemia that was being treated, or his lymphoma. Similarly, the Essen patient had a stem cell transplant, again with a CCR5 mutated donor, meaning that his cells become hard to infect, and they were a bit surprised to see that the virus went back up again afterwards. You can see the spike in the middle just after the transplant. But when they did phylogenetics, they found that actually he had got a completely different virus from what he had before, and that the virus that he now had uses the alternative receptor, the X4 tropic receptor. So instead of going through the CCR5, so in other words, the stem cell transplant may be protecting him from CCR5 viruses, but not to go through the X4. And in fact, when they did deep sequencing, they found that he did have some X4 viruses within his population before the stem cell transplant, and it was exactly the same virus that was found afterwards. So it was not that he got reinfected, it's that he had small populations of viruses that use the X4 receptor rather than the CCR5 receptor, and that's what led to the breakthrough afterwards. And it was interesting, Timothy Ray Brown, the Berlin patient, was in the meeting and giving his perspective, and he's now taking PrEP himself, because although he's cured, he wants to take PrEP to stop the possibility that he could get reinfected with a different type of virus that doesn't use the same receptor. So it's a sobering picture for cure. It's also sobering when people have been trying the first, not big, but 60 patients, but the first real clinical trials of approaches to cure were presented in Amsterdam, the River trial, which is the so-called shock and kill approach, or kick and kill, where you give an agent, in this case voronostat, to wake up the latent virus in cells, and then you use the immune system, bolstered by some vaccine-type products, to try to kill off those cells that came up. And unfortunately, there was absolutely no difference in various markers over the follow-up between those people who had been randomly assigned to the cure approach or to the standard approach, suggesting that it really hasn't made a difference to the viral reservoir. And the suggestion is that that may be because the immune system is not good enough. And we still think that there are approaches to reinforce the immune system. This paper is an old paper that got a lot of attention and still is getting a lot of attention. Louis Picker's group in Oregon that showed that in monkeys, a vaccine that he's created actually eliminated the virus from more than half the monkeys they gave it to, despite it being a very pathogenic virus. So the hope is that we can modify the immune system in ways that would be part of the cure strategy. So this is using vaccines to maintain remission. However, again, as Steve Deeks, who was being a bit bleak in the conference, said, there have now been 100 therapeutic vaccine studies performed, and almost all of them have really not shown an effect in that therapeutic vaccine way. And this is just another example of one of Tony Fauci's showing no difference between what happens when you treat people with the vaccine or the placebo for treatment. So for prevention, I think we can be a little bit more encouraged. There are two huge prevention trials ongoing in the field. The approach study, one of those, the so-called Janssen Mosaic vaccine, provided some interesting updates. They have also been published recently in the Lancet, so in a way it wasn't so new. But this is the one-year follow-up data. So we've now gone, they presented data at 1 year, and 1 year later it's 2 years after the vaccine program started. They've seen no serious adverse events. And so they're very encouraged. And this is the immunology in blue, showing what they've seen going up now over to 2 years with strong responses, immunological responses to the virus. And in orange, superimposed, are the studies they've done in monkeys, and showing that the monkeys have similar immune responses. But the good thing in the monkeys is that you can challenge them. And in monkeys, those levels of immune response are sufficient to prevent monkeys becoming infected. So they're very encouraged that they're getting strong enough immune responses that in a monkey would prevent the monkey becoming infected with HIV. So it's encouraging. It's a 4-dose vaccine schedule, and that vaccine is now in big-scale trials. We'll have the results in a couple of years' time to know whether that can really prevent HIV acquisition with 4 doses. And that's where I will stop. Just to say that there were big studies presented on the big-scale population studies, the so-called universal test and treat studies, the final results of SEARCH, the final results of the Botswana study, the Namfia study, some data from POP-UP, but not the final results, and some comparisons of the 4. And we're delighted that next month, I think almost certainly the 27th of September, but we'll advertise it to you, we're going to be having the POP-ART investigators come to Geneva, and we'll have a specific discussion unpicking all the different results here, because it takes an hour in itself just to talk about those things. So I'd now like to pass on to Rachel.
Thank you very much, Peter. I'm going to talk about prevention, key populations and testing. And again, as Peter said, this was an incredibly rich conference, and this is very much a whistle-stop tour through it. So just some real highlights. The picture I wanted to show on this slide here is alongside the main conference. For the first time, we at WHO joined forces with UNAIDS and UNITAID to have a Building Bridges session throughout the conference in the community village. And this gave us an opportunity really to listen to communities, engaging communities on HIV testing, on PrEP, on key populations issues, particularly on drug use. It was incredibly rich and engaging, and a huge amount of work, but I think a very, very successful collaboration. For testing, I just wanted to highlight two things that came out in the conference, was launched in the conference. As Peter said, WHO launched its PrEP app. We also launched our testing app. So our guidelines are now fully available on cell phones for use. And IOS, along with WHO and others, launched the differentiated service guidelines for testing, and this really is designed to help countries think more strategically about the approaches they should use to get to the last 90. And prior to the conference, we had a workshop with 7 countries where we looked very ruthlessly at what they were doing for testing and seeing where they could improve this to be more efficient and effective. And this, I think, is going to be a big part of work that we do together with the Global Fund, UNITAID and UNAIDS over the coming years. We know we've done pretty well in Southern and Eastern Africa reaching women. Reaching men is less good. And I just wanted to highlight here a nice study from Malawi where they did something really simple. They just offered testing at the weekends, and you can see the nice long queue of men who were wanting to be tested, and you can see on the graph in the corner there how the blue bars for men. You can see how this really increased, just offering something as simple as offering testing at weekends. What you know from the lines is what we also know. As you get the coverage up and more people are tested, the positivity rate or the yield will go down. And it's this difficult balance between volume of testing and diagnosing those who are left still undiagnosed with HIV. It's going to be more and more difficult and more costly as we reach towards the 1890 and beyond. Partner testing is another way to reach men. This study here from Kenya showed that young women found it very advantageous to offer testing to their partners, offering self-testing. And this is an approach that has been used in several countries, but this is the first study with young people. And again, we worry that this is going to be difficult for young people, potentially cause difficulties in relationship, but that wasn't borne out in this study at all. Highly acceptable, and no worries about intimate partner violence, with the caveat that this always has to be done in the context that it's voluntary, and women are supported to make that decision whether it's safe or not to offer testing to their partners. Self-testing continues to be a great hope. There were numerous presentations and sessions on self-testing. I'm just highlighting three here. One from France, where self-testing is now offered in pharmacies, and this was a survey looking at the pharmacists and the populations who receive self-testing. Key populations who acquired self-tests from pharmacies found this great. Pharmacists really enjoyed their new role. They felt they needed a bit more training, and price is a barrier in France. I think it's around 25 euros, and this is obviously a barrier for poorer people, and we must continue to really work to get prices down, even in the high-income countries. The pop-art study in Zambia looked at linkage to care, and found that just distributing self-tests, it was difficult to really show great linkage to care. But if you had some assistance in the self-testing process with a community distributor enabling to support that linkage, you could increase that linkage. We do worry that people will self-test and not link to care, so some thought must be given to do that. Something that I found very, very encouraging. We've really concentrated on self-testing, giving it out in communities, giving it to community-based organisations to distribute. But this study from Malawi, Catherine Dovell and colleagues, showed that it was also really successful within a clinical setting. We know that clinics are incredibly busy. Family planning clinics don't offer testing. STI clinics often don't offer testing. Outpatients don't often, or if they do, they suggest you go somewhere else to get testing. But but providing self-test in the waiting room, and you can see from the green bars there, really increased access to testing and had a similar positivity rate to other approaches. And I'm very encouraged that this is a way that self-testing could make testing much more efficient, particularly in family planning and contraceptive and other reproductive health services, where people are inevitably having sex, so at risk from HIV, and also knowing their status while they're choosing their family planning choices could be very empowering and informative, so they can make self-choices. Cheryl would never forgive me if I had a slide on the STAR project. The STAR project is a UNAIDS-funded huge project on HIV self-testing, and really has given much of the evidence to date on self-testing. And just two things really to highlight here. In the table on the right, self-testing really does increase testing rates amongst the groups that we'd like to be tested, who are missing out, the men and the younger people. And Frances Cowan and her group in Malawi and Zambia really showed that of the huge number of self-test kits, 178,000, there were very small numbers of adverse events, and sometimes these adverse events aren't as adverse as they seem, and marital breakup following a discordant result in an already unhappy and difficult marriage may not be in the long term the worst outcome. But I think we can be reassured that if self-testing is given in a sympathetic way, we will have very low levels of adverse events, but we need to continue to monitor and give information to communities about when and when not to self-test. Partner notification is also something that WHO has been very keen at supporting. We released guidelines a couple of years ago to support increased access to partner notification as a way, as a public health way to increase testing of a group that are inevitably more likely to have HIV than others, partners of people with HIV. And here I just wanted to highlight a study from the Ukraine, which was using a coupon-based partner notification to reach partners, and you can see the green dots are the people without HIV and the red dots are people with HIV, and they're given coupons to give to people in their sexual networks to come forward for testing. And this again is a way of increasing the efficiency of testing. From Zimbabwe, a very positive example of index testing partner notification through sexual networks. And again here, highly efficient, with the positivity rate from this approach in the order of 30 to 40%. And this is obviously much higher than any other testing modality. And this is in a context in Zimbabwe where you already have very high testing coverage. So getting to that last 20% using techniques like partner notification will be efficient and effective. Key populations, UNAIDS issued their miles to go, really highlighting that key populations everywhere are at the centre of the HIV epidemic. And even in southern and western Africa, there's a significant proportion of new infections amongst key populations. And at the conference as well, IAS and partners released their differentiated service delivery guidelines for key populations, and I urge you to have a look at those. Tim Brown from East West Centre in the US gave a fantastic talk on why we must refocus on key populations, and this data is from Asia. And on the right there, you can really see that as a proportion, the grey bars are people who are not directly key populations, and the other colours are from key populations. You can see that over time, key populations continue to represent the majority of new infections. The populations within those key populations is changing, and while we have better programs for sex workers, better programs and changing patterns of drug use, those groups' new infections are decreasing, but there is a really a significant rise in infections amongst men who have sex with men. And Tim Brown finished his talk by saying, key populations really need to remain at the core of response. This is absolutely key in all regions outside Africa, but also focused and an increased focus on key populations in Africa will have a huge benefit. And Peter Piot really said the same thing in a slightly different way. He was talking about the 10-10-10 or the 10-19-27, and he said, with our existing approaches, we're leaving populations behind, and those are the key populations. If we don't turn our attention more effectively to key populations, we won't achieve those goals. He also particularly highlighted migration and mobility, and that HIV funding was under threat, particularly for prevention. Key populations really were at the heart of the conference in Amsterdam, and I could have spent several hours talking about key populations and the great projects that were presented there. I'm really just giving a little highlight of two areas: the intersectionality between key populations. Men who have sex with men and drug use really have to be taken together. And I also wanted to say there was real hope. I went to one session which was getting prepped where it's needed for MSM, and it was amazing to see nearly 10 different countries represented by MSM networks talking about PrEP. I don't think we would have seen that 5 years ago. Go down, one down for me. And the other population that I really wanted to highlight was transgender populations. Again, highlighted relatively well at this conference. Many more sessions on transgender, but still big challenges, particularly for funding. And I wanted to also just highlight the voices of transgender women at the conference. And Lara, here in the corner, was at one of our sessions, a wonderful new voice talking about transgender issues and taking PrEP for young transgender women. And finally, other prevention, and Carl Denny, who probably isn't here but would never forgive me if I didn't mention the need for other prevention, which was really not covered massively in the sessions. PrEP really, as you can see, I gave up counting when I found more than 200 abstracts compared with condoms and VNMC. But there were important things about male medical circumcision. We have to celebrate the fact that 18 million male circumcisions have been done, and we worry about safety, but very reassuringly from Mozambique, in their program there, where they've carried out nearly 1 million male circumcisions, very, very low levels of adverse events. And this is a program that we need to celebrate and continue, but make sure it continues to be safe and broaden the impact of it. And finally, we've got to think, if we're going to reach men and boys, think where they like to go. And I'm always been very struck, particularly in southern and eastern Africa, the interest in football, and ways to find men are often at sporting events. And there was a very nice abstract here looking at ways to increase information about male circumcision and offer testing at sporting venues. I'll stop there now. Please do look at Nduku's plenary on prevention. She really gave an excellent overview of where we are and where we need to go. And I really want to thank my team and colleagues from UNAIDS and UNICEF who made the conference very vibrant for us all.
Thanks, Rachel, very much. And we will move straight on to Meg.
Thank you, and I apologize that I shamelessly looked at all the slides online, and mine are not as organized as others, but what I think we took away from the conference, that there was a lot going on about treatment, and I'm going to cover our WHO updated guidelines on treatment, dolutegravir, and then something on STIs and SRH linkages, because I think the conference, for those of us who were there, we were running from one dolutegravir session to another, which I think was great, and let's see if we can pull it together for this session. So what we do know, and this is a slide from WHO up at the top, is that countries are moving towards bringing dolutegravir into their first-line treatment, and that we have 4 currently fixed-dose combinations that are on the market that include an FTC of tenofovir, 3TC or FTC, and dolutegravir. So it's the era of dolutegravir, and our new recommendations support, and I just wanted to make sure that everybody got the new recommendations, that we are supporting dolutegravir in first line, can be recommended as a preferred first line regimen for people living with initiating ART, excuse me, and that's for all populations, and Martina will talk about infants and children. But what I do want to highlight for women and adolescent girls of childbearing potential, and we use the term in our ART guidelines as potential, because we know it's not just limited to age range, but it's around those who are very interested in becoming pregnant, that we can use dolutegravir, but with a note of caution, and we'll walk you through this. We updated our network meta-analysis, and really the reason to choose dolutegravir is it came out on top compared to efavirenz 600 on viral suppression at 96 weeks, treatment discontinuation, and CD4 recovery. However, the final impact, mortality, AIDS progression, and severe side effects are comparable. So in many ways, there are lots of people walking around saying this is the best drug ever, but all drugs have problems, and it didn't come out on top on every indicator, and so we have to keep that in mind as we move forward over longer term issues like measuring mortality. So this recommendation was also, we looked at the safety concerns around the use in the periconception period, and we were acknowledging in the risks and benefits that there are some qualifications around using this dolutegravir in women in childbearing potential. So our guidelines include a note of caution, and later in this presentation I will share the results that were presented from Botswana that helped inform this concern about using dolutegravir in the periconception period. But what we end up saying in our guidelines are that dolutegravir is safe when started after the period of risk of neural tube closures, up to 8 weeks after conception. And adolescent girls and women of childbearing potential who do not currently want to become pregnant can receive dolutegravir together with a consistent contraception method. Now, there may be lots of arguments around what that is, and we're working on implementation guidance to help explain and help countries as they move forward with these guidelines. But in this period, the good news is that we have an efavirenz-based regimen that can be used during this period of time, and that countries also need to balance the risks and benefits when they're also looking at things like pre-treatment drug resistance and fertility levels and availability of contraception. We also have encouraged a woman-centered approach in all of this, and I think that was why there was such a great number of sessions at the ARV conference, at the AIDS conference, because there was a lot of discussion around what is a woman-centered approach, what is choice, what is informed consent, have women been consulted, and how do we ensure that when guidelines are taken up in countries that all women who are affected by this recommendation are at the table and involved in decision-making. This is another slide that just gives, I think this is a take-home slide that you can look at later, but just to say where the alternatives are, and the one thing to note that we still have as alternatives efavirenz 600 and efavirenz 400, and that we have now recommended that nevirapine can be used in special circumstances where other alternatives are not available. I I think the other thing that we shared, and oftentimes WHO is also, there's a concern, is WHO progressive enough? Are we setting up a standard that is different for low and middle income countries than it would be for high income countries? And this slide really highlights that WHO is probably as progressive, if not more progressive, than more of the other normative bodies in terms of using dolutegravir. The first group, this is a little tough to see for me, but this is people who are not, women who are naive. We indicate that we don't want people changing dolutegravir in late pregnancy, because I'll show you later it's very effective at bringing the viral load down. And that if they are in childbearing age or potential, using effective contraception should be an option for using dolutegravir. If women are on dolutegravir when they become pregnant, again, we are not recommending switching out the dolutegravir, whereas other normative agents are switching this out. And I think this will evolve with time, but we need to get some real implementation experience using dolutegravir with women. And again, we are now very consistent with all of our other normative agents, normative bodies, in that dolutegravir is a recommended first line. In second line, we also made a recommendation that dolutegravir can be used with an optimized nucleoside reverse transcriptase inhibitor backbone, so an NRTAI backbone that is optimized. Dolutegravir can be used as a preferred second line. Again, in children, and Martina will address those. And this is new for us to bring dolutegravir into the second line, and I also believe it's slightly different than other groups that would like to see it used with a non-optimized backbone. But the only data that we had to inform this recommendation was the Dawning study that was updated during the AIDS conference, which essentially shows that compared to lopinavir-ritonavir, there was better suppression at 48 weeks and fewer discontinuations. But essentially, this is only one study, and in this trial, they also look to optimize the backbone. And again, this next slide just shows what would be a preferred first line, a preferred second line when you have what is your first line. So really we're potentially starting to challenge a bit about the standardized first and second line. So here we note that if a person starts on dolutegravir in their first line regimen, a preferred second line regimen would include a PI boosted with ritonavir, either atazanavir or lopinavir, with darunavir being an alternative. And if a person starts with an efavirenz or an nevirapine first-line regimen, then dolutegravir can be used in the second line. And what we can see in the third line now, we're actually even bringing in the use of darunavir and dolutegravir as a dual regimen, possibly in third line. So this means that dolutegravir is being found in our recommendations in first, second, and in third line. So sequencing becomes a little bit more challenging as we move forward, and I think the implementation of this we have yet to see, but there's quite a bit of work that will need to be done with this. And lastly, I think Vindy will talk to this, but we have also indicated that we can use dolutegravir in the treatment with tuberculosis with rifampin at a double dose, and this is based upon the studies from Kelly Dooley's inspiring study. What we have recommended is that we need an optimized backbone when we use dolutegravir in second line, and also if one is switching from first to second line to use dolutegravir, we would prefer to see a viral load in that switch. So these are all around implementation considerations. Lastly, we also recommended that we can use dolutegravir in PEP. So there you go, dolutegravir in the water, as some would say, but in this case, we would see it as an preferred or strong recommendation for a recommended preferred third drug in post-exposure prophylaxis. I think what's going to be important across the board, that note of concern for women of childbearing potential is for first line, second line, third line, and PEP, and we will need to see how this plays out in implementation. In terms of ART, there was quite a bit of other data presented on dolutegravir. Number one, the study from Sapamo from Botswana showed the updated results. And if you can read that, I think it's difficult potentially to see, but this shows the rate or the proportion of neural tube defects first reported out in the paper that they submitted, or the abstract, as 4 out of 426 pregnancies, now updated at May 1 to have 4 out of 596 pregnancies, but still, if you see that confidence interval on the left, it does not overlap with other neural tube defects from either using an efavirenz-based regimen or other regimens, or no drug at all. So there maintains in the Botswana an increased risk in those women who've been exposed in the periconception period for neural tube defects with the use of dolutegravir, and they are now rapidly scaling up so that they can cover more than 91% of all pregnancies in Botswana, to be able to know if this holds out as more pregnancies come to full term and births, as well as we know that Brazil and Kenya are actively working on the same. We also know that dolutegravir, on the flip side, and this is a very difficult message to be able to articulate to people so it doesn't become confusing, the Dolphin study showed that dolutegravir is well tolerated, has good PK and PD levels, and good viral load suppression results when started late in pregnancy, and therefore is a good regimen for late pregnancy presenters when you want to reduce transmission of HIV between mother and child. So again, a good use of dolutegravir in pregnancy, and so that helps to confuse the message for many. Dolutegravir coming out of Brazil, where they're using it in triple therapy, has been found to be more effective when compared to efavirenz, but this is within a programmatic level, and essentially their suppression rates are approximately 85%, which is quite good. Dual therapy, can you get rid of tenofovir? And the Gemini study shows that dolutegravir 3TC is non-inferior to dolutegravir, tenofovir, and FTC. So if there is a tenofovir risk or a side effect, the Gemini study says that you can simplify down to 2 drugs. However, and I think this is finally putting to bed the discussion around dolutegravir monotherapy. There was a study, Monarch-A, and I think if people were in the room, there was a lot of discussion and a lot of distaste for this study, because essentially it showed that if one took a person who was suppressed and then put them onto dolutegravir monotherapy, over time they failed after 24 weeks and out to 48 weeks. And the virological failure was 7 in that group. It was a very small study, but then there was quite a high level or proportionality there of integrase inhibitor to dolutegravir resistance emerging. So essentially now, really, dolutegravir maintenance monotherapy, dolutegravir in early treatment or acute, or in maintenance really should not be used. So monotherapy, in my vision, is out. How are we doing? TB treatment, I'll skip. Doravine is still on the agenda. I'm not sure where we're going to use it, drive forward, but it seems to be in naive patients to be working better than using darunavir or ritonavir in first line. Not sure where this is for low and middle income countries. We heard about River. My take from the River was we also had increase in the functional CD4 and CD8 T cells at 12 to 9 weeks in those who were vaccinated. So even if it didn't reduce the reservoir, there was some change in immunology. We need more work on these, and I think there's 2 vaccine trials that are underway that really I feel are going to be interesting when they come out. STIs, very briefly, because I know I'm probably over time. There was a 2-day syndemic meeting on STI and HIV, and it was very well attended. And I think there was some excitement because overall, the epidemiology of STIs is not getting better. It's getting worse. There's a lot to do with transmission dynamics. There's a lot on management. We're finding that there's more resistance. There's a lot of things that we need to learn from HIV in terms of sexual health. And the WHO is there, but we need to now move forward, and I think a lot of the WHO work was highlighted in this meeting. I think just to say now, in terms of HIV and STI, it's always been a two-way street, but I think this meeting really highlighted that it has to be a two-way street, and that the work in HIV needs to, and PEP and PrEP and TASP really can also now be used as a platform to start working on STI. We have, in STI world, we have 1 million new STIs per day. So it's a huge epidemic going on. We have 4 curable STIs that are increasing over time, if you see that, and that includes chlamydia, gonorrhea, trichomoniasis, and syphilis. We have a new problem of countries that are reporting to WHO GASP, where we are getting superbugs with gonorrhea. So I'm having trouble reading that up there, but if you can read it, we have cephalosporin resistance up in the left-hand corner. We have azithromycin resistance and ciprofloxacin or ofloxacin, other ciprofloxacin resistance. And I think the fluoroquinolones just should not be used in low and middle income countries any longer to treat gonorrhea. So what are we going to do? There was talk about vaccination. There was talking about also moving away from syndromic management, because some believe that some of these results have come from the syndromic management. We see gonorrhea going up all over the world, primarily in men, more than women, and I think this is related often to MSM, and similar to some of the work that was highlighted by Rachel, is that we really need to use some of the online approaches, partner notification, etc., in e-health to try to address this. New diagnostics, lots of talk about using the expert platform for being able to identify and do an etiological identification, especially because many of these platforms can use the DNA and RNA PCR. So I think there was just a huge conversation going on about using PEP and PrEP services to do STI screening regularly, moving from syndromic management in Africa to etiologic management. And I think that this is going to be the next step, and I know that our colleagues in WHO off here and RHR are working on this. And I have to call out, there was an awful lot on SRH and HIV linkages happening at the meeting. I didn't speak to any of the results, but just to note that with partners, WHO and many of the other partners, I think including UNAIDS, made a call to action to attain universal health coverage through linked SRHR and HIV interventions. So I think there's also going to be quite a bit of work that we're going to have to do on that in the future. Thank you. And thanks to everybody who provided me some slides for this.
Meg, thanks very much. And we'll move rapidly on to children. And Martina is going to talk to us about what she heard about pediatrics there during the meeting. Martina, have you got a clicker?
Yeah.
It's all yours.
Thank you very much, Peter. So in the interest of time, I'm going to start by advertising someone else's webinar. It's a webinar that UNICEF put together a couple of weeks ago with Lee Moffinson, and she provided a fantastic overview of the key pieces of evidence that were presented at the conference for pediatrics, PMTCT, and maternal health in general. So I would definitely recommend to look at that webinar. Recording is available online, and I put the link right there. So because she did such a fantastic job, I'm not going to try to replicate that, and I'm going to focus more on the key pieces of key products that were launched during this conference for pediatrics, and I'm going to start with our guidelines, of course. And I think it's fair to say that in general, the pediatric sessions, both at the pediatric HIV workshop that happened just before the conference and during the conference, I think it's very clear how some of the notion about how we're struggling to timely identify children living with HIV and reaching them with treatment was really confirmed and emphasized again and again. And I think that the other quite depressing piece of data that continued to be presented at these conferences is the virological suppression piece that is coming out of the surveys conducted, the population-based surveys. So every time a new FIA is presented at these conferences, you can see that when you look at the age breakdown, the virological suppression is particularly poor in the young children and in the adolescent age group. So it's very clear that we need to provide better treatment options for these children, and that's really the focus of the update of our guidelines. And in those guidelines, we did consider integrase inhibitors across the board in different age groups, but of course we were mostly interested in dolutegravir and the opportunity to really harmonize first-line treatment across different age groups. And in doing so, we've considered efficacy data generated in the adult population, but also safety and PK data generated by two key trials that I'm going to go back to, which presented further data during the conference. We know we have very limited experience in real-life settings and with dolutegravir, but we have some, at least in Europe, and that's encouraging. And we know that there's a number of advantages that really promote dolutegravir as a key drug that has a huge potential for children and adolescents as well. But we know we have evidence gaps, and I think that's clear, and there's a lot of work undergoing to fill those gaps, but it's never fast enough. So overall, I think that the key principles behind these new recommendations in terms of pediatric treatment, I think it's really the need to move away from NNRTI-based regimen as a result of the extensive NNRTI resistance that is being documented in a number of different countries, and the need to introduce dolutegravir as soon as possible. And while we do that, use the most potent drug that is not an NNRTI-based regimen. With that, you can see here in the table a summary of the recommendation. As you can see, first-line regimen being recommended now is an integrase inhibitors-based regimen across the board, with raltegravir preferred for neonates and dolutegravir preferred for children. Now, we know that currently dolutegravir is only approved above 6 years and 15 kilos, and so raltegravir is listed there as an alternative, particularly in settings where lopinavir, ritonavir solid formulations are not widely available. And I think it's important to know that now NNRTI are really considered to be used for special circumstances and should not be used otherwise. I want to note also that with the information we currently have available, and I'm going to go back to this a little bit, we can actually use 50 milligrams, so the same dose and the same formulation that we have for adults, down to 25 kilos, and that's going to be an important simplification. And also to note that TLD can also be used below 40 kilos, but only in adolescents and above 30 kilos. So this is an important piece that will have to be reminded again and again when interacting with countries. Our recommendation also support the use of dolutegravir in second line, as Meg mentioned, and that's true for children as well. So whether you fail on a lopinavir-based first line or on a efavirenz-based first line, dolutegravir can be used as long as you are at the moment 6 years and 15 years of weight. So in all of this, it's important that we acknowledge that the limitations, the limited data we have available for dosing in the different age and weights is something that limits the implementation of this recommendation right now. But we have important data that were presented at the conference, and the first piece is really the Odyssey PK sub-study that is one of the sub-studies that are included in this important trial. That is the only trial actually looking at efficacy in first and second line for dolutegravir in children. And this study that presented their findings at the pediatric workshop highlighted how the current approved dosing that is used in Europe, for example, is associated to low exposures when looking at PK parameters in children. In particular, here in the slide you see two weight bands, the 25 to 30 and the 30 to 40. And you can see that the study compared the existing recommended dose by approved dose by EMA, which is on the left, the 25 milligrams and the 35 milligrams, as opposed to the 50 milligram, which is the one that is being tested in the study. And as you can see, this is important to note that these are the lowest level present in the blood. But as you can see, by increasing the dose to 50 milligram, we can reach the targets that are being set based on adult data. And this is an important point, because I think it's going to cause a lot of confusion, and it's something that we need to be prepared to address. The clinical relevance of these low levels is still to be clarified, to be honest, particularly in settings where you have viral load monitoring and you're able to have a very close follow-up of patients. And this is the reason why the label hasn't been changed yet, and the EMA hasn't really changed their approval. But for context like the one we are targeting with the public health approach, it's clear that we can't afford to use this low dosing, and that's the reason why the WHO recommended dosing for this age group and weight bands is 50 milligram, which of course helps us because it simplifies a lot of things and helps us to use adult formulation that are currently already available in countries, and in a way speeds up the implementation of these recommendations in some settings. Important to note that this higher dose was safe, and at least in the short term, and that more data will be needed, of course, in the longer term. But there's really no signal or concern at this point in time that this higher dose would have any safety issue. Important to note that this trial, together with the 1093 trial, was a critical piece of information that helped us to accelerate introduction of a new drug in treatment guidelines, and moving from a sequential approach, as we've done in the past, into more of a parallel approach where these studies are conducted almost at the same time and then release data as they move ahead, so that the guidelines can be revised, and then in developing a recommendation that can now be implemented as these studies are completed and generating new evidence for the dosing in the younger age group. And all in all, this is really accelerating the introduction of a more effective drug, and potentially increasing the number of children that have access to it quite significantly. So the other trial that I mentioned, 1093, which allowed approval of the drug in children, presented new data at the conference for the younger age group, and I'm showing this just to say it's not ready yet, but it's around the corner, hopefully. And This study is designed as a typical PK study where you look at the dosing and then observe the virological suppression over time. In this younger age group presented at the conference, virological suppression was achieved very well with the dosing, with the dose being tested. But when looking at the different age groups and weight bands, it was observed that the lowest concentration was a little bit too low, particularly in the 2 to 6 years of age, and which is the reason why they're now testing a slightly higher dose, both in this trial and in the previous trial, as I've showed you. So all in all, things are moving forward. So hopefully next year we'll have these data completed and able to use dolutegravir all the way down to 4 weeks. Another point I wanted to make here is that, of course, we are all excited about dolutegravir, but it's important we keep watching out, because out of the 1093 trial, we see that there were about 3 virological failures, and out of those, 2 had resistance to integrase inhibitors. These were all adolescents, and they were all associated to poor adherence, of course, but this is just a reminder that dolutegravir is not really a magic bullet, and there's a lot that needs to be done in order to provide these drugs with the right support. Important to note that when it comes to implementation, we had the opportunity at the conference to launch 2 important pieces of work that were developed in a collaborative way by a number of different stakeholders, many represented in the room. One piece is the optimal formulary that helps countries to select their products and to implement the guidelines. And the other is a transition brief that was developed particularly with the lead of the ARV procurement working group, really to support this difficult phase where multiple products will be available and probably not enough manufacturing capacity readily available to address the demand there. But more information is provided there, and I would really recommend people to share this as much as possible in country. In terms of implementation, it's also important we really reflect on the fact that when we start these these girls on dolutegravir, that we keep them on dolutegravir, and that we do the best that we can to ensure that we really put in place the critical enablers so that they can receive dolutegravir in a safe way with contraception and with adolescent services that are really sensitive to the characteristics of adolescence. And there was a lot brought up during the different sessions with regards to the fact that these recommendations as they stand right now, they may be perceived as a further barrier to for adolescents to have access to the right drugs for them. And we really want to emphasize the fact that it's important that we develop our narrative to countries and encourage them to use dolutegravir, and just to make sure that they put in place the key pieces to enable integration of with sexual reproductive health services that are suitable to adolescents. And that will obviously require thinking about the policies and whether for example, age of consent needs to be relooked at, and so on and so forth. I didn't notice any specific piece of work presented at the conference that looked at specifically integration of SRH with HIV services for adolescents, but there was quite a lot in looking at different models of care to provide services to adolescents. So I think there's certainly opportunities there to do a better job. So finally, our recommendation also include a piece on EID and ensure that early infant diagnosis can happen in an accurate way. And as you know, we already recommend to undertake a confirmatory test upon a first positive result when we do EID. But we know that that's really implemented poorly in many countries. Now, the problem is that as we do a better job in preventing transmission, we do have fewer infection in the blue boxes, but we also know that the relative proportion of the false positive results that we can have for EID can be higher. And so particularly in countries that did very well, or countries that are on their way to really decreasing remarkably mother-to-child transmission, we really need to put in place additional elements to be sure that false positive results are minimized. And we can do that by acting in the lab, where we have a lot of very different technologies that are very sensitive and that pick almost anything. And the problem with that is that at times low levels of viremia can actually be a result of contamination. And so it's important that we introduce a indeterminate range that enables us to identify those low-level viremia and retest them to make sure that they're actually infected. And this is really another key recommendation that is included in our updated guidelines, and important to put this in the context of really a shift in the way we looked at the algorithm as a multi-test algorithm, so more as a process rather than a one-time event, and really the importance to think about the new technologies. And really a shout out to this piece of work that was presented at the conference. Many of you know about the ECBA UNAIDS project that has really taken POCID to 9 countries and has looked at different models of implementation. And it's interesting, I think, to see that point of care has been particularly beneficial in settings where in entry points such as the pediatric inpatient and patient wards, which is where actually children really need to start treatment as soon as possible. So the time, reducing the turnaround time is very critical. So definitely flagging these pieces for your attention. And I'll stop there, but I want to certainly remind people of some of the products that were presented at the conference. You can find them online. The AIDS-Free Toolkit, that is a result of a lot of work, collaborative work by many different institutions, and there is a piece led by Mary Mahi on the estimation of pediatric infections, and also these are the toolkit developed with UNAIDS and others to really accelerate development of pediatric formulation overall.
Martina. Thanks, Martina, very much. Vindy, talk about TB, the biggest killer of people living with HIV.
Thank you very much. Last but not least, let's talk about death. TB-HIV highlights at IAS 2018. Presenting this on behalf of myself, I'm the TB focal point in the HIV department, and Annabelle Badley and Lele Rangaka, who are the TB-HIV points of contact in the TB department. There was a lot that took place related to TB amongst people with HIV at the conference this year. There was a TB pre-conference, bridging the TB and HIV communities, and as a lead up to the UN high-level meeting on ending TB in September in New York. During the conference itself, there were a number of abstract and symposia sessions, and WHO co-convened a side event on TB preventive treatment, as well as a session on providing health services in prisons in preventing, treating HIV/TB. There were many sessions on at-risk groups and et cetera, and a keynote address at the end by Bill Clinton. 38 abstracts, very interesting topics ranging from drug-drug interactions, community outreach for case finding, both HIV and TB, implementing IPT policies, ART scale-up, TB mortality incidence, including in the large UTT studies, novel diagnostics, new algorithms all across the cascade. And I went through those 38 abstracts and basically picked out what I thought were important and interesting. The first one that Meg referred to as the Inspiring trial from Kelly Dooley. The 48-week results were presented here. The 24-week results had been presented at CROI this year. It was, this is the trial that compares double-dose dolutegravir with TB treatment versus efavirenz in the ART regimen with TB treatment. And essentially, it concludes the same at 48 weeks as at 24 weeks, which is that it's efficacious. The intent to treat analysis showed pretty equivalent viral load suppression rates between the dolutegravir group and the efavirenz group. It was well tolerated, very few adverse events, no withdrawals from adverse events, high TB treatment success rate, and basically just confirming what we already know, that we can double the dose of dolutegravir when the patient needs to have TB treatment with rifampin. This was very interesting. Result from one of the big trials that will be discussed in September that Peter may have referred to, the SEARCH trial, which was a very large trial of pair-match communities, 32 rural communities, up to over 150,000 patients, followed for 3 years, where half of the communities had an intensive test and treat package that was delivered. Patients, the way they wrote it, patient-centered multi-disease package of interventions, including annual testing campaigns and universal rapid ART initiation. And the outcome they were looking for was reducing incidence, HIV incidence, but they did not find a difference in HIV incidence, but did find significant benefits in increasing ART coverage, reduced viral load suppression, and decreased HIV-associated mortality, and 59% decrease in HIV-TB incidence. And there's a little graph on the corner that the blue line is the HIV-TB incidence. So that's good news. There was an interesting study of bedaquiline replacing injectables, second-line injectables in South Africa, and 12-month follow-up to look at whether the outcomes were similar, and they were similar even in the HIV-infected subgroup. Providing support for the use of bedaquiline in these settings. There will be new WHO guidelines out on MDR-TB management, and there's already a statement which has brought bedaquiline up to a higher level for inclusion in MDR treatment regimens. The status trial, which was presented at CROI, had 48-week results presented at IS. Similarly, showing this, well, I'll just describe it. They were looking at ART-naive HIV-infected adults with CD4 less than 100, half of whom received extensive TB screening and then TB treatment if the screen was positive, and the others who received empiric TB treatment without this testing. And also, both groups were started on ART. ART was started right away in the TB screen negative group, otherwise 2 weeks after TB treatment, looking for death or invasive bacterial disease as an outcome. And essentially, they found that the outcomes were similar, that the systematic treatment was not superior to the screening and targeting treatment in this group, but there was higher drug-related toxicity in the group that was empirically treated. The numbers are there, 23.4 versus 15.7 per 100 person years of grade 3 to 4 drug-related events. This one is a cohort study from Thailand that just reinforces what we already know, that TB incidence decreases with ART duration, but is higher than in people, general population risk. And it's also associated with risk of death. Okay. Let me go back. Another study from Indonesia shows the benefit of IPT, again, for reducing TB incidence. I'll just say there were a number of studies looking at implementation of current existing guidelines from WHO and supporting what we already know from our systematic reviews, but interesting that this is happening, that people are implementing and looking at questions. Something a little bit new was study on Expert Ultra, which is the new version of GeneXpert, showing higher sensitivity and specificity, actually, in adults, in CSF fluid in adults with meningitis. And this is a test that's already being recommended by WHO. Another assay, a high throughput platform assay in South Africa called the COBUS TB assay, was compared to GeneXpert and Abbott real-time assays and found to be comparable. So this is also something WHO will be investigating and you'll hear more about. An interesting study on approaches to diagnosis from Malawi, where they used ultrasound findings of effusions and lymphadenopathy and correlate them to urine lam in very sick patients with TB and HIV, and found a correlation and think that this could be interesting. So if you're in a setting where you have a bedside ultrasound but you don't have urine lam, this could be of use, potentially. And another study looking at CRP as part of an algorithm. And we will be looking as WHO at various diagnostic approaches in the future. So this could be interesting. Stop there. There was a lot more. I would suggest going to the website to see what else is there.
Right. Well, first of all, thank you those who've stayed the course. Thank you to our absent presenters and to our present presenters.
I asked people to send us questions by email. Yesterday when I sent out the announcement, I got one. I'm not particularly sure if this has already been addressed, but this talks about the dolutegravir from David Chapanta. His question is WHO considering updating the guidance on the use of dolutegravir or toning it down, given no confirmation at IAC on dolutegravir's impact on the neural tube defects? The guidance from WHO used information from a well-designed observation study and presented it in the form of results of a 3-arm randomized control trial, effectively concluding that DTG caused no neural tube defects. Probably DTG was responsible, but we cannot say from an observation study point of view with certainty that neural tube defects were a result of DTG, can we?
We could. It would be very helpful if you could send that question forward, and I can look at it in greater detail. The DTG, the neural tube defect, was an association that was seen in Botswana from an it's a observational prospective study embedded into a national program that has looked at women, all women who've received, whether they've received dolutegravir, Favirs, or any other drug, either before pregnancy, during pregnancy, and after pregnancy. And because this study was set up actually to identify neural tube defects, it's probably got the best information we could gather around neural tube defects in any of the countries or any of the studies. Currently, there are, because it's such a rare event, it can't be studied in a clinical trial setting because you need so many numbers to be able to find a rare event. But it's a severe rare event. It's one of those birth defects that we really take very seriously. So WHO put out a statement and then also refers to this statement of concern of safety around using dolutegravir during pregnancy in the first, either right before becoming pregnant or up to the 6 to 8 weeks after conception, when the neural tube is in the process of folding over and becoming finalized and developing both the brain and the spine. So we see the results that came out of Botswana SAPAMO study as enough information to give us concern about the safety. And when you multiply that over 15 to 20 million women who might need to take this drug, if this plays out as a true effect, because it's an early effect, it's an early signal that we see, if this plays out as a true, it could really mean quite a bit of deaths for infants that otherwise wouldn't have this problem if they weren't exposed to the drug. Now, that being said, I think he's right. We need to look at more data as it goes forward. Is the only outcome that we're worried about is children being born with a neural tube defects? We have other outcomes that we're concerned about. We're concerned about women having a suppressed viral load for their own health. We're concerned about decreasing the transmission between mother to infant. And what I showed the study was from Dolphin is that dolutegravir is quite good at that and safe in that period of time. So I didn't show all the data. So I think David and I, and maybe with other folks, with Peter, we can sit down and go through the data. But it wasn't a trial. It wasn't reviewed in our guideline committee as a trial, the SAPAMO study. It is a signal of risk, and we have then put in a note of caution around using this drug during that period of time with all the caveats that it means. And we have committed as WHO and with all other partners to come back and look at this signal of risk in April or so when more data are available, and we're actively following all the data that come out. Currently, it has not been identified as a non-issue yet. So it's still a concern. Since May, it continues to be a concern.
Thank you.
In which case, I'd like to say thank you very much to our participants who are still online. I think there's an enormous amount there. When you go over the presentations, when you come back to it, feel very free to send us emails, because we're delighted to engage with all of you. We do see one of the benefits of going off to these conferences is that we need to be a conduit to share the information back to our staff in countries and elsewhere, and we're always open to have discussions about what is an enormous amount of information presented. Thank you all very much.